Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello, Rhonda.
Hello, David, and hello to David Antonuccio, who we introduced last week, and we're so happy to have again this week. Just to remind you, this is the Feeling Good podcast. We're at episode 488, and Dr. Antonuccio spent decades researching and practicing, treating patients in the fields of depression, anxiety, smoking cessation. He studied the effectiveness of psychotherapy. He's worked in the area of ethics, and we would love to have you again talk to us about your work and your career and your philosophy.
Sounds good. And I think we have to give some credit to your background too. But I love working with people with the PhD in clinical psychology because of the critical thinking. And I know you picked some of that up in your undergraduate at Stanford, which I think you loved. And
I did love Stanford.
Around Stanford and Lake Lagunita and all those cool places. But then I think in your graduate work, you worked with the famed but now aging Peter Lewinson.
He passed away last year, yes.
Oh, I'm so sorry to hear that. Yeah.
Good man.
Yeah, I met him just once, but he was very big on patients have to do their psychotherapy homework or he won't work with them. I give them 4 or 5 weeks to see if they can get
Right.
up to speed. And he was very much big on behavioral interventions, but it must have been a great graduate program too, because of the sharp critical thinking skills that you've brought into your entire career.
He was a fantastic mentor, as was Ed Lichtenstein. That's where I did my smoking research. With Pete Lewinson, it was depression. But he was big on what is now, he called it increasing pleasant activities, but now we call it behavioral activation, getting people moving again, exercising, doing fun things. And when you're depressed, patients will say, well, what do you mean? I'm depressed. I don't feel like doing anything fun. And we would say, we know, but we want you to do it gradually, just a little bit, kind of priming the pump. And that turned out to be a very powerful intervention for depression.
Before we get into your exciting reveal on SSRIs and violence, you mentioned your first work on smoking research, and I don't know if you visit us, go back to that amazing experience you had where you were working with 2 things on the nicotine patch. One, was it safe, and the other, was it effective? And you had data from both wings of the study, and I think you had kind of an interesting experience.
That's true. I had forgotten about that. I must have told you about that. This was a multi-site study. I think it was at 10 VA hospitals. And we were, I'm going back into my memory banks here. We were, I think it was underwritten by Mary and Merrill Dow, one of the patch makers, and they wanted to establish that the patch was safe in cardiac patients. As I recall, we had more than 600 patients who had cardiac problems using the patch, randomly assigned patch users to placebo patch users. And we
before we let's make it simple for our listeners. So half of the 600 would get a placebo patch on their arm, which isn't going to do anything to interfere with anything in their body, and the other would get the nicotine patch, which is intended to decrease the desire to smoke and help with nicotine withdrawal from giving up smoking. But also wanted to see, is that going to be safe for the patients from a heart perspective?
Right. And that's what they were really interested in, the safety. They weren't really interested in how effective it was, but they were interested in the safety. Now, I, as a researcher, was interested in both. So the data were analyzed, and it was shown to be safe, and our article was published in the New England Journal of Medicine. But I had seen the data on the effectiveness, and it was not more effective. The placebo patch did just as well at helping people quit smoking or not smoke as the active patch did. And so I felt we had a moral obligation to publish the effectiveness, even though it was not effective, right? So I asked the lead researcher if we could do that, and they didn't want to. They said the industry the company didn't want to do it. And so then I tried to get the data myself through the Freedom of Information Act. I'm trying to recall how this all panned out. And I was blocked there. So then what I did was I wrote an editorial explaining why I felt researchers had a responsibility to publish all of the data, not just the data that the company wanted, because the human subjects that participated in this study were given a contract saying that they were contributing to science. And so I felt like we would be letting them down, betraying them if we didn't publish all the data. So I wrote this editorial, sent it to the New England Journal of Medicine, and they wrote the lead researcher and said, we're going to publish his editorial unless you give him the data. All the data. And so the next day or so, I got all the data.
Oh, cool. And then I didn't know that part of the story.
Yeah. And then I was able to collaborate with the lead researcher. I didn't want to exclude anybody, but I just wanted these data published. And I didn't care who got credit. And so we were able to publish it as a follow-up brief article or letter to the editor about the fact that it did not improve outcome. It just was safe. But the drug company had already accomplished what they had set out to do, was get this patch available over the counter, which it still is today, right? That's what they were interested in, not the fact that it wasn't effective. And I think to this day that the nicotine patch is not an effective treatment unless people learn some other skills to manage their urges and thoughts and behaviors that lead to smoking. You can't just slap a patch on and have that be the end of it. And so, but that was my introduction to how the industry could corrupt the data that are produced and what is actually published.
I was working with Diane Spangler, who's she was a Stanford postdoc, and like yourself, a clinical psychologist and a brilliant researcher and a lovely woman who then went on, because of her religious background, to BYU. For her, she was a postdoctoral fellow of mine at Stanford, and she's actually we've reconnected not long ago, and we're collaborating on a paper, and we just got our IRB permission, I think, to publish this paper that I had mentioned to you when we had lunch.
Mm-hmm.
But at any rate. What were we talking about?
About how the company steered the.
Yeah.
Matter of fact, one other comment about that I just remembered too. Your question prompted it. Yeah. I don't think the researchers ever saw all the data. I think they were managed by the industry people. And this is often true. And I think the original article that was, I can't prove this, but the original article that was published in the New England Journal was ghostwritten by a company writer. So not only was it ghostwritten, but it was ghost analyzed. That's what I believe. And that's often true.
Oh, yeah. That's terrible. But at any rate, Diane and I, there was a multi-institution study, I think 6 institutions, including Stanford, and it was a paper on cognitive therapy versus antidepressant versus a combination of the two at these 6 sites. I believe that was the research design. And Diane and I got permission to get access to the data because we had process papers that we wanted to write, like things like is attributional style different from cognitive distortions or something like that. And does this rumination theory of Susan Nolan Hoeksema really hold up? Various basic science things that had nothing to do with outcomes. And so we had actually drafted 6 papers. And we were very, very excited because we were doing it all with structural equations, and we found some really, really cool findings. But then it suddenly dawned on me that there was a site difference that was equal to or bigger than the claimed efficacy difference in the different locations. So like the cognitive therapy at one location would have a radically different outcome than the cognitive therapy at a different location, and the same with the psychopharmacology. It did not make sense statistically. And so we contacted the people to say we'd like permission to track this down because it could be any number of things. It's most likely some kind of a data error, but that could also be someone's intentional desire to change the data. And we believe if we can have the full data, we can analyze this and publish the explanation, because this really brings into question all of your results, because the result that they wanted was the politically correct one, that the combination enhanced either one, but our data really questioned that. And then finally we got the feedback from someone at Stanford that we no longer had permission to even publish our 6 articles on process.
Right.
And that if we were interested in remaining with Stanford, we would back off right away.
Yep, that's the kind of thing that happens, David. I'm so sorry that happened to you after all that work. People deserve to see those results. You're right about the politically correct. You'll still hear it today. Well, of course, they'll say the combination treatment is the best option for patients. And it's not. Well, my review of the literature is it is the best option compared to the drug treatment alone, but it's not better than the psychological treatment alone.
Exactly, yeah.
And of course, when you add the medicines, you increase the risk of all the medical adverse risks and so forth. So anyway.
But anyway, it was just that these pressures exist, and they exist potentially in all of us, and everyone's filled with denial. No one wants to say, I'm quite biased and I'm willing to fudge the data. If they said that, at least they'd be honest.
Yeah, that's true. Well, I mean, human beings are vulnerable to this. Absolutely agree with you. One of our fallibilities.
Well, let's get on to some of the goodies that we've been promising. We always hear about that do antidepressants, especially the SSRIs, all the new costly ones, enhance the likelihood of suicide. And they do double the risk of suicide as compared with placebos, which is quite alarming. And that's been shown in huge studies involving thousands of patients. But do they also increase the risk of violence? And we don't hear about that, partly because some of the research and some of the court cases, people get silenced. And I know you were silenced, and you were involved in a leading court case on this. But now you're apparently have been freed from the prison of having to keep everything secret, and you can talk about what happened. So can you tell us about that amazing court case that you were involved in?
Yes. First, one nuance: the studies showing a doubling of the suicidal behavior and thoughts. Nobody in those studies committed suicide. I want to clarify that. So, but these were only 6-week studies, and they still found the doubling of behavior. And these are studies where the suicidal patients were excluded before the study even started. So, this is a serious problem when you see a doubling of suicidal behavior and thoughts within 6 weeks. Okay, so just to clarify that. But now,
that's good to know. Thank you.
And the issue of whether these medicines can cause violence, and we see a mass shooting somewhere, and often that will be raised as a question: were they on something that could have been contributing to this, and so forth? And I really want to give a nuanced answer to this, and I want to be accurate because I don't want to mislead people. Most people who are involved in these mass shootings are not on these medicines, okay? So it's an impossible question to answer. You'd have to randomly assign patients to antidepressant, thousands, maybe tens of thousands of patients to antidepressants and to placebo, and see if you got more shootings, right, in the group. It's impossible to answer. We can't tell if antidepressants are the proximal cause of any particular shooting, even if the person were on antidepressants. But is there a possibility that they could cause some kind of violent behavior? And you think logically, if it increases suicidal behavior, could it not? Why would the violence only be self-directed, right? That's I think the question you're raising. Well, Healy actually did an analysis.
This is Healy.
David Healy, yes, of the data on Paxil from studies that were submitted to the regulatory boards in the UK, I believe it was. And I told you the suicidal behavior risk was 4% in the drug condition and 2% in the placebo condition. Well, in the Paxil studies with over 1,000 patients, it was 0.65% in the drug condition and 0.31% in the placebo condition. So you see those numbers are quite low, but it's still a doubling of the risk, right?
Yeah.
So to put it in plain numbers, that's 34 extra violent patients for every 10,000 treated in the drug condition compared to the placebo condition. Am I making some sense there?
Yeah, it's more 34, which is 65 minus 31, 34 more violent cases for 10,000 people who
treated. Yes.
Paxil.
Yes. And so again, that's a very low number, but you still see that doubling, right? Yeah. And these were events that were coded as hostility events in these studies that included aggression, violence over. Nobody murdered anybody. Again, these are mostly 6-week studies, but that just gives you an idea of the possibility it could be a factor. But I will say it's unprovable in a particular case. But you raised the issue of the case that I was involved in. And this...
How were you asked to be...
You went out on a shooting spree right after taking Paxil?
Say this again?
Was this that time that you went out on a shooting spree right after taking Paxil?
No, I did not go on Paxil. I did not go on a shooting spree. Thank you very much. And Rhonda, you had a question?
How were you invited to be a part of this trial?
One of the local attorneys asked me. This was a woman, just to give you a little background, she was 72 years old. I'm not going to name her, even though it is public and it's possible to find. Were you able to find it on the internet?
I was
Yes.
able to find it on the internet, yeah.
Okay. She was a kindergarten teacher, had taught kindergarten for something like 33 years. She was happily married to her husband for 42 years, and no history of problems with the law, no history of suicidal behavior, no history of violence towards anybody. And she was put on Paxil because she was feeling anxious about multiple things, including her husband was developing some early signs of dementia and so forth. But they were happy, they were secure, they had 2 adult kids that they loved and so forth. And she was put on Paxil, and then it started interfering with her sleep a bit, and so they added maybe she was started on a sleep medicine, but then she was starting to feel a little depressed, and then they added the Paxil, and the first sleep medicine was Ambien, and the second one was Ativan that they gave her. Eventually they took her off the Ambien, but so within 6 weeks of being prescribed the Paxil, 20 milligrams, and the Ativan, I think, was 10 and a half, something, I forget, 10 milligrams, I think. She got up in the middle of the night and stabbed her husband 200 times or something around that. And she doesn't remember any of it, didn't at the time I did the evaluation. And if ever there was a case that suggests that something like this could be caused by the medicine, her case was it. Because of the legal risks and so forth, because she was charged with homicide. And she said, when I interviewed you, what a sweet woman. So she was not in an agitated state when I saw her. She just says, I must have done it. They tell me I did it. The evidence suggests I did it. I don't remember anything about it. And she described some of her symptoms prior to the event, and she had symptoms of antsiness, can't sit still, wringing her hands and fingers, legs moving, and so forth, a kind of akathisia, which is one of the possible side effects of these antidepressants, where you feel so uncomfortable in your skin, you want to stop that feeling any way you can. And it is a known risk of antidepressants. So my assessment was that she was probably experiencing akathisia at the time this event occurred, and that coupled with the Ativan, that she was in some sort of fugue state, and she engaged in this act without being aware of what she was doing. But because of the legal risks and so forth, they bargained to manslaughter, and I was allowed to testify at the penalty hearing, and which is when I presented the information and the data that I just talked about to you. And my position was that, even though science is not a popularity contest, and even though this might be a minority position, that is, that these medicines could cause this kind of behavior, sometimes the minority position is the right one. And these data suggest that it's a possibility, and I believe that she was among those 34 extra violent people in the 10,000 treated. And the judge seemed to agree, because he did let her go with time served and go home with her adult children with no more jail time. And that's about as good an outcome as you can hope for, almost. Better would have been complete acquittal, but they didn't want to risk a trial, even though I might have wished that they had gone to trial on this case, because a kindergarten teacher with no history of violence or severe mental health problems would be a reasonable case to try, I think. I understand why they chose not to do that.
Are these
Awesome. Thank
discussed with patients before they're prescribed? Is this possibility discussed with their patients?
I'm going to say most times no. People can read the warnings, but even the black box warnings are almost never discussed with patients, in my experience. I trained psychiatrists for 32 years at the medical school here, and of course, I would always encourage them to inform their patients of the potential risk. But usually, the appointments are so short, and it's very difficult to squeeze in all the information. If you really were to inform people fully, you'd probably take a full half an hour just to do that, right? And so people can be consumers and read these warnings, but I don't know anybody who does, to be honest.
Wow, that's shocking that the psychiatrists aren't explaining the possibility because they don't have longer than 10 or 15 minutes with their patient?
I think that's commonly the case. There may be some folks out there who do take the time to do it, or give a clear handout of risk, a paper handout this person can read. But I think it's unusual. I'm sure that if there's a psychiatrist out there who do this, I am sorry for including you in this critique, because this is important. And as part of informed consent, it would be a good idea to let people know specifically about the risk, at least of the clear risk of suicidal behavior included in the black box warnings, but also agitation, sleep disruption, sexual dysfunction, all those other things. I think patients should be informed about before they take their first pill.
I know you advocated for a patient bill of rights with psychotropic medication. If you're going to update that today, would you include these kind of patients' informed consent as mandatory part of prescribing this medication?
Hell yes, absolutely. Yes. Yeah. Yes, it should be clear. Probably it would involve a single page, bullet pointed, bold faced summary of potential risk.
Yeah, even that would be easy.
Yeah, something like that. Yes. Patients should know about that before they take the first pill. I think they would want to know. Most want to, and those that run into trouble later. I mean, it's also very difficult to come off these medicines. Some people call them withdrawal effects. Some people, the industry prefers a term called discontinuation effects. If you've been on them for a while, it's very hard to come off for many people. Not everybody, but many. And there are people who have written books. One of my colleagues and friends, Brooke Seam, wrote a book called, I always get the title of her book wrong, but about her experience coming off, may cause side effects, and about her experience in coming off of antidepressants after being on them for 15 years. She was put on them at age 15 when her father died, and she didn't realized that they could be causing some of the symptoms she was having. So she waited till she was 30 to come off, and her experience is well documented in her book. It's terrifying, actually. And not everybody's experience of coming off is as difficult as hers, but
Steam, S-T-E-A-M?
S-I-E-M, Seam.
Oh. How do you balance the different, you're a professor, you have a private practice, you're a researcher, you're an advocate. How do you balance all those roles? Do you see any conflict within them?
Well, it was difficult because it's almost like being in the lion's den, because all the time, when you're a psychologist, as a professor in a psychiatry program in a medical school where drug industry influences are prominent. In fact, middle of my career, are you familiar with the American Medical Students Association? David, you might be. It's called AMSA. It's a student group that are part of the AMA. Well, they went somewhere back, I don't even remember when it was, maybe I'm going to say roughly 2000. They went out and graded university medical schools for how well they separated themselves from the industry influence, right?
Oh, yeah, that's a good one.
Isn't that a great idea? They got a report card. Every medical school got one. Guess what grade mine got?
The school you worked at?
A D?
F.
F.
Oh,
Wow.
F.
We failed. So who would be on a committee to fix that? Yours truly, along with some colleagues, wonderful colleagues, and we did our best.
That? You can just go and fix everything.
What's that?
How fun
Yeah,
is that?
yeah.
You can just go and fix everything.
Yeah, what a great idea. Well, actually, I was honored and privileged to be on this because I felt like we needed to do something. So we started drawing clear lines about, when industry could come in, about disclosures, about the obligation to publish all the data if it were underwritten by industry, these sorts of things. And we were actually able to raise our grade to a B. I don't know what it is today, but we deserved the F that we got. And I'm hoping we deserve the B, and I maybe I hope it's even an A now, but I don't know what it is now. But this was something, and many schools got an F. You can find it on the internet. There are report cards. I don't know if they still do this sort of thing. This was groundbreaking, really, and it was powerful. Can you think of anything more powerful than a group of students saying, we want this fixed? We can't fix it ourselves. So what we're going to do is grade you all. You grade us. We're going to grade you. What a brilliant idea. Whoever came up with that idea, have them on your podcast.
Can
Really.
we look up Stanford right now?
What's that?
Looking up, Rhonda? Can we look up Stanford and see the grade?
I don't know if they have new grades too. This is 20 years ago.
Yeah, well, we can see what the grade was then.
You might be able to. Yeah, it was AMSA, and it was grading each medical school about their pharmaceutical boundary with the pharmaceutical industry, something along those lines.
Okay.
Are you looking it up, Rhonda?
Yeah.
Oh, cool.
I'll look it up.
I'd be interested. Yeah.
You started when we were talking to you about what we were going to talk about on the podcast. You started talking about the story with Dr. John Nash.
Oh,
would that fit in now? While I look this up,
it would. If you want to hear a story that nobody else knows about,
we do. We want to hear that.
It's a secret story, but he did not swear me to secrecy. Okay.
How cool is that?
Okay, so you might remember the movie A Beautiful Mind. Right? Do you remember that, David?
Yes.
Dr. Nash, Nobel laureate in statistics at Princeton. Well, my Stanford girlfriend at the time was a graduate student at Princeton, and I had spent a year there when I was at Oregon during my internship, and I went to see this movie, and she had told me that Dr. Nash was wandering the halls when I was there, and I didn't know this, but so I was I don't remember where I was. I might have been in Reno by the time this movie came out. I don't know if you can figure out what year this movie, Beautiful Mind, came out. But
what was the movie? The Something Mind?
A Beautiful Mind.
Oh, A Beautiful Mind. Yeah, that's right.
See if you can figure out what year that came out, because that'll tell me where I was. When I made this phone call, I saw the movie, and I thought, and my friend Karen had told me.
It was 2001.
Okay, so I was in Reno, and my friend Karen had told me that he had been at Fine and was still there, Fine Hall, the statistics hall at Princeton, where she had done her graduate work. So I was familiar with the location. So I don't know what inspired me, but on a whim, I called up Fine Hall. I called up the number that was associated with Dr. Nash's name, and I called the number, and it rang, and then a woman answered the phone. And I said, "Hi, this is Dr. Antonuccio. I just saw the movie A Beautiful Mind about Dr. Nash, and I was wondering if he's there, if I could talk to him." And she said, "Oh, yeah, sure, here he is." So she hands the phone to John Nash, and I was surprised, one, that I got him, but two, that he was willing to talk to me. And I said, "Dr. Nash, I just saw the movie about your life." I said it was inspiring, how beautiful it was, and about your struggles and your recovery and so forth. I said, "I have a question for you." I said, "The movie depicted the medications as the reason for your recovery. And I said, is that the way it was? And he said, no.
Oh, he did?
He said, I stopped the medications. He said, what saved me emotionally was support of family and friends. And he said, now this part I might have a little fuzzy, but what I remember the bones of it though. The screenwriter's husband or partner was a psychiatrist and was afraid that if they put that angle out on the story that he recovered without the medicines, that people would stop taking their pills. So they changed the script so they wouldn't prompt people to stop their medicines thinking that they could recover. He said, but in my case, they were not critical to my recovery. And in fact, I had stopped taking them long before I started to recover.
Wow.
From John Nash's mouth to my ears to your podcast listeners. There you go.
And so the movie was afraid to give the honest, historical and accurate perspective on what helped him recover.
How it would have, they were afraid that patients who were taking these medicines would stop taking them. And so beyond that, I don't know who they were affecting, but they were, I think maybe someone was legitimately afraid that would hurt these patients. I don't know. It might have been afraid of hurting the drug companies. I think probably some people were legitimately worried that it would hurt patients if the accurate information was portrayed in the film.
Yeah. Do you know if the drug companies had any financial interest in the film, any controlling?
I do not know. That's a really good question. I never looked into that. I do not know.
We could ask AI.
You might get an accurate answer.
Yeah.
Well, I can tell you that I can give you the answer about the AMSA study in Stanford.
Oh, yeah.
And this is an article from 2008. It doesn't give them a letter grade, but it said, because of that study, as a result, Stanford University School of Medicine no longer accepts any support from pharmaceutical or device companies.
So maybe that was the response. So there must be an earlier rating somewhere. I'm thinking there must be. In other words, in 2008, if they are saying they responded to their grade, interesting. That's interesting. Well, good. So that's a positive outcome. Stanford never doesn't accept it anymore. Interesting.
So Stanford no longer receives stipends from drug companies or device makers
for part of their training, right? Yes.
Yeah,
that's a great outcome. This is because those AMSA students really had an impact on Stanford Medical School. I mean, a real tangible impact.
Yeah.
You know what? See if you can find somebody that would be curious and interview them on your podcast. Somebody who came up with that idea, the genius who did that, came up with the idea of grading medical schools. There must be somebody who gets credit for that somewhere.
Oh, yeah.
And that would be an interesting person to talk to, because in my opinion, they are heroic.
Oh, yeah. Yeah. Check it out. See if we get that person on our podcast, Rhonda.
Okay. That sounds good.
Because I remember when I was first, we moved from Philadelphia to Stanford around 1995, and that was certainly before 2008. And I remember even then the drug companies would be bringing in lunch for the psychiatric residents and leaving preprints and things like this for the residents to read. And I thought I'm going to check this out because, my somewhat interest in statistics. And there was some new drug that was a neuroleptic that you could give in emergency rooms for agitated patients. And they did a study comparing it with Haldol, which is a fairly somewhat harsh neuroleptic that we had back in the 60s and 70s.
Yeah.
And and it showed a graph of the change in the scores on some agitation scale, and it looked like it went down like something like, this is just all from memory, but like a 50% decrease with their new drug compared with Haldol. And then I looked up the scale, and they had only presented the scale findings from value 50 to 60.
Mm-hmm.
And the scale went from 0 to like 180 or something.
Yeah, that's one of the tricks, is narrowing the range of
yeah. So if you looked at the reduction in terms of the scale, it was pretty much meaningless.
Yep.
But the way they squeezed the data down, it looked like, Mount Everest was cut in half.
Right. Yep. That's one of the tricks, David.
Yeah.
Well, if you could redesign the U.S. mental health system from scratch,
that's what I've been trying to advocate for.
Yeah, what would you do?
In the psychotherapy side, I'm for throwing out 100% of the schools of therapy.
Mm-hmm.
And that's very popular when I mention that in my talks and things.
Yeah, I bet.
and then forcing everyone to use scales like mine or your own if you prefer, but that measure here and now how the patient is feeling at the start and end of every single therapy session, plus rate the therapist for empathy and helpfulness and your satisfaction after the session, and then the therapist can have those ratings and find out for the first time exactly how effective you were or weren't, if you can take it, and most can't, and exactly how accurate your perception of how empathic you are and your understanding of the patient's feelings is, how accurate are the therapist's feelings. And some research I did at Stanford, as you're familiar with, Rhonda, shows that those are not accurate. The therapist can be talking to patients for 2 hours and be less than 5% accurate in how the patient is feeling in terms of depression or anger or suicide or anxiety, or estimating how empathic they are. How does the patient see them? And so we'd have a data-driven psychotherapy. And it would be like a licensure for an emergency room. You can't license an emergency room without having an X-ray machine and a blood pressure cuff and, blood drawing equipment and, access to a CAT scan or an MRI, or you have to do a scientific approach, basing everything on measurement. And if I was redoing it, I would develop a whole field of treatment of psychiatric problems on that. And I would get rid of the DSM, calling them all mental disorders. There are some mental disorders, schizophrenia and bipolar, and probably a few others. But, I would, hack everything to pieces and start all over, like the Copernican revolution. They threw out everything and came up with mathematical models to understand how people change. That's what I've been working on. That's what I strongly believe in. That would be my take on it. Let's hear what Antonuccio says.
I think your suggestion is outstanding. There's another psychologist by the name of Barry Duncan who believes in measurement as strongly as you do every session. And he's written about this as well. Here's what I would change. The screening of many patients involves giving them, especially depressed patients, a pill the first session. I would say, no way, let's try a non-drug intervention first. And that's based on a lot of research showing that the psychological treatment alone is just as effective as the medicines in the short run and has more enduring benefits. So that's a rationale for doing that. Now, what happens in most medical settings is the patient will see a medical provider first, who immediately starts a pill. I think that's a terrible strategy, and it happens almost everywhere. And
I'm going to tell you why you're wrong.
Okay, tell me why I'm wrong.
Because the way the billing is set up, you see, let's say we're going to spend a 50-minute hour with the patient. If we if we prescribe something, we can charge an extra $900 for that, and then another $900 for the psychotherapy session.
You figured out the flaw in my logic, David. You cut through everything, and I know you're being tongue in cheek because I can see it in your face. But this is a really serious problem, because this means patients are exposed to the risk right off the bat, and that's really, I don't know. That would be the one if I could change something. So a different starting point, let's say, for every patient that comes in for mental health treatment.
Yeah.
And then add your rating scale on top of that.
Yeah. And I would like to see it where people at your level of intelligence are required to get into the field. Like my roommates from Amherst were very high-powered. Stiglitz went into economics, Phil Allen went into solid-state physics, and things like that. And those guys, I mean, they were human. They have some political issues like we all do, I suppose, but it was based on what you know and what you can do. And when I look at our field and the quality and the intelligence of the people doing psychotherapy, it's worse than shocking to me. And I'm probably paranoid and all biased in my thinking. But I just see it as profoundly disturbing.
Yeah. Yep. Your buddy Stiglitz, didn't he write The Physics of Immortality?
Who?
Stiglitz.
Yeah, I think you might have mentioned that to me, and I haven't looked the book up. What did he say in there? Like we're all going to be immortal in AI or something one of these days?
Basically, yes. And he proves it from his perspective with mathematical equations that are included in the appendix. It's a fascinating book, but it gave me a headache to read. But the idea is that, yes, we will all eventually be immortal through AI. Anyway, I can't even explain it, so don't ask me to.
No, well, it's awesome, and he was sure smart when he was in Amherst, and he hasn't let up yet. But that's what I think we need, and real training, like what we do in the Tuesday group, Rhonda, where you do a role play and you get immediate letter grade. Here's what you did right. Here's what you did wrong, and do that over and over and over again to give people a chance to learn certain skills and tools. And tools with patients, because I get sucked in, on the after the Sunday hike. There was someone in the Sunday hike who was kind of upset, and I stupidly got sucked into trying to help. And then she started resisting, and I got real frustrated. And it didn't occur to me until Sunday night when I woke up in the middle of the night and said, "Oh, that's the mistake I made." So I emailed her Monday morning and said, "I made a terrible mistake. Let's start all over and do it right."
Nice.
You, in addition to being brilliant, from my perspective, David, you also are humble, and that combination is beautiful to watch.
Yeah, you're the same. You have the academic humility of that your research is all flawed, and we should be critical of what we do, rather than trying to promote ourselves through our research, and that is the goal of top clinical psychology programs. But many aspire to it, but few really live that.
Thank you.
Well, again, thank you so much for coming onto our podcast and sharing your experience with us.
But we haven't had any music yet.
I was just going to say, can you end this podcast with one more beautiful song?
I could do that if you want. I'm gonna put the phone down in front of me here.
Yeah.
So
also, can we publish the electroconvulsive therapy song?
Yeah, the song Buzz.
Yeah,
yes.
Buzz.
Yeah, that was written for Charlie Helmer, who was being forced to undergo ECT against his will in the Midwest. And I was so inspired by that story. I wrote the song and recorded it with Mike, and it's called Buzz. And we put it on his website. And within a week, and not because of our song maybe, but because other people were also concerned about this, the judge rescinded the order and stopped the forced ECT.
Oh, that's awesome.
Yeah.
That song was called Buzz. I'm going to play for you a song now that I didn't write, and I don't know if you can put it on your podcast or not. If you can't, you can eliminate it. But the reason I'm going to play it is called In the Air Tonight by Phil Collins. And it's a song about an inability to forgive. And Phil Collins wrote this song when he was getting divorced. But it captures the struggle that many people have with forgiveness. Now, having said that, in the pain expressed in the song, again, I feel it is a release because I have done the research. I've actually published on the topic of forgiveness. Forgiveness is one of the most powerful human gifts from one person to another, but also to yourself. It doesn't mean you can't hold people accountable for their actions, but rather you can hold them accountable, but it means you're willing to let it go at some point. And it can't be forced. It has to be the right timing. You have to practice empathy and some other things. There's a psychologist at Stanford. I don't know if he's still there. Fred Luskin, who wrote a book called Forgive for Good, which I found inspiring, which tries to teach people the skills of forgiveness. And the person who is this song is about could have benefited from that, I think. Because there's all kinds of health benefits, physical and emotional, by forgiving. Sometimes easier said than done. Can you hear the guitar okay?
Yes.
How's that?
That's good.
Yeah, sounds familiar
I
too.
can feel it coming in the air tonight. Oh, Lord. I've been waiting for this moment for all my life. All my life, oh, Lord. Can you feel it coming in the air tonight? Oh, Lord. Oh, Lord. If you told me you were drowning, I would not lend a hand. I've seen your face before, my friend, but I don't know if you know who I am. But I was there and I saw what you did. I saw it with my own two eyes. You can wipe off that grin, 'cause I know where you've been. It's all been a pack of lies. I can feel it coming in the air tonight. Oh, Lord. I've been waiting for this moment for all my life. All my life, oh, Lord. Can you feel it coming in the air tonight? Oh, Lord. Oh, Lord. Well, I remember, don't worry. Could I ever forget the first time, the last time we ever met? I know the reason why you keep your silence up. You don't fool me. The hurt doesn't show, but the pain still grows. It's no stranger to you and me. I can feel it coming in the air tonight. Oh, Lord. I've been waiting for this moment for all my life. all my life alone. Can you feel it coming in the air tonight? Oh, Lord. Oh, Lord.
Thank you so much.
Awesome, beautiful, heartfelt.
Forgiveness is at the heart of that, and a challenge in getting there. So,
Yeah.
anyway, that's what I have to offer you today.
Yeah.
Thank you so
That's
much.
beautiful.
My pleasure. You guys are awesome. Thank you for inviting me. If, anyway, I'm just pleased as punch to have been included and invited today. So thank you both, Rhonda and David.
Yeah. Well, we might try to get you back for Q&A or something. Maybe if some of our listeners write in questions for you.
That would be fine.
Yeah, that's really
maybe
fun.
We could have a little follow-up Q&A session. So if you've been listening to the last two podcasts and you want to ask a question of one of the world's top, maybe the world's top researcher and critique of research methodology in the behavioral sciences for psychotherapy outcome studies, antidepressant drug studies, anti-schizophrenia studies, and more. Antonuccio is you can't get higher on the ladder than talking to this gentle giant. So if you want to ask some questions, and we get 5-10 questions, we'll suck him back in for a part 3, and we can shoot some questions at you and pick your brain and have another wonderful session, and have some more music too.
I would be happy to come back. But you guys are awesome. Thank you for inviting me again. I can't live up to what you just said, but I still appreciate it anyway.
Yeah. And one last thing is we're completely commercial free on here. We've accept no money for anything at all. And so we don't promote anything. But all that being said, the name of your band is Rainfall.
Rainfall, yes, with a capital F, capital R, capital F, Rainfall. Yes, that's correct.
And if I'm a listener and I want to hear, the produced versions with your colleague and all the instruments and all of that, where would I go to hear some of this?
You can find our music on SoundCloud, on Apple Music. Also Apple Music. Also Spotify. It's on other streaming services as well, but those are the 3 main ones.
So
if they have any trouble finding our band, they can put in my last name, Antonuccio, and Rainfall, and it should come up. But
and we can put your contact info in the show notes too, I presume.
Sure, that'd be fine. Yes, absolutely.
And do you ever perform live?
A photo of your house and address if there's any haters there who need to come in person.
Yes, perfect. Yes. And she's asked if I ever perform live. No, unless I'm on a podcast. So there you go.
Okay, thank you so much.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.